Hi, I'm Dr. Mollie Marti, and welcome to Resiliency Matters. This is a special pandemic edition that we are filming virtually with Dr. Mike Osterholm. Mike is the founding director of the Center for Infectious Disease Research and Policy, or CIDRAP, at the University of Minnesota. And he is the author of a New York Times best-selling book called The Deadliest Enemy. Welcome, Mike.
Thank you. It's good to be with you.
You have been on the front lines of infectious diseases for decades now. So greatly appreciate the work that you're doing on behalf of all of us today with this coronavirus pandemic. And yet you have been talking about this for so long. I actually pulled up, I came across my desk, a quote that you said on Oprah in 2006, talking about pandemics. So 14 years ago, you said, "Let me make it real clear. This is not a probability. It is going to happen. It is going to happen. What we don't know is which strain it's going to be and when it's going to happen. The bottom line is we have a lot to do to better be prepared." So you talked about, we would be shutting borders, have supply chain problems. I don't know that you mentioned toilet paper or not, but you were spot on with so much of this. Talk about that, how long you've been ringing this bell and what you're experiencing. How prepared or ill-prepared were we for this?
Well, thank you, Molly. I appreciate the very kind introduction. Unfortunately, this has been something that I've thought about for a long time. As a student of infectious disease history, I understood the impact that influenza pandemics had had on the world over the course of most of our human history, even back to Hippocrates, who described a classic influenza pandemic that swept the world even back then. Typically when these occur, it's a new virus in the influenza family that emerges for which no one has any kind of protective immunity. We were caught by surprise with this particular one, since it's a coronavirus, different than influenza as a virus, but unfortunately it is acting in very many of the same ways, so that we're actually seeing this worldwide transmission via just breathing, taking in someone else's air, and we're also seeing the dramatic impact that it's had. I think to give you some sense of where we're at today, this particular disease has now become the #1 cause of death in the United States on a daily basis. Think of that, in just 12 weeks ago, this virus wasn't even in the top 100 causes of death in North America, and where it's at today. And so I think it gives a subtle reminder of why we needed to prepare for this, and the fact that it is here now, and it will be with us for months to come.
So talk a bit about models. I saw that CIDRAP released your first report, and you had a few different models about how this might play out. And I know you have approach to models that I think we all could benefit from. But talk about, how do we model this, and what does that mean?
Well, first of all, let me just define the model issue. I think that's an important thing. As someone who has had a fair amount of statistics in my educational career, I appreciate what most people think of in terms of, they think of statistical modeling as big black boxes that you throw some things into and out comes this forecast what will happen. Those have occurred throughout the course of this particular pandemic. And as we often say in the modeling world, no models are right, but some give us interesting and maybe potentially helpful information. So from a statistical standpoint, the models that we're often talking about are nothing more than just assumptions that are made about, well, we go right or we go left, you go up or you go down. Will this make an impact, will it not? And that's been the source of great debate about what these models really mean. What we did actually was slightly different. And what we're really talking about here is that if you understand how infectious diseases are transmitted and why they continue to get transmitted or they stop, a large part of that has to do with immunity of the population, meaning that you have protection built up based on either having been infected with the virus and developed a response, or from a vaccine. And we know with a respiratory transmitted agent like this, the one where you're just breathing and you pick it up, that in that case, you're not going to see the transmission slow down at all, given the kind of virus this is and how it's being transmitted, until you get at least 60 to 70% of the population immune, again, either through illness or through a vaccine. We don't have a vaccine right now. We're not going to have a vaccine for some time. The obviously most optimistic view is that maybe early next year we might have one. I think that's overly optimistic. So the only other way we're going to get there is through actually the occurrence of cases, meaning people getting infected like we're seeing every day right now. To get to that 60 to 70%, we have to march all the way from 5 to 15%. That's where we're at right now in this country, with only very few places like New York even approaching 15%, the vast majority of the country in the 5% level. So when you think about all the pain and suffering, the death, the economic devastation that's occurred already, it's only happened in the first 5 to 15% of this pandemic. So what we did is we laid out how are we going to get between here and 60 to 70%. And we really only have a couple of choices. One is it a flu-like model, where if it is, like the pandemics of past, you take 1918 as an example, we saw cities in the United States that had major epidemics in the spring wave, or this, what was we call the spring peaks in 1918. Cities like New York and Chicago were hit very hard, where cities like Minneapolis and Detroit, Baltimore, Boston, Philadelphia, really no cases at all. Very sporadic. It was not clear why that happened. But the most important thing is everything just went away then after about 8 weeks of these outbreaks, only to come back with a vengeance in the fall of 1918, where then we saw widespread illness throughout all of North America. And that wave continued for a better part of almost 2.5 months. And then it came back again later in 1919 and 1920. That's what we think is one model. We could get to 60 or 70% that way. That would be devastating because the big spring peak in 1918 was absolutely overshadowed by the huge peak of the fall of 1918. And that's what we have to understand. That might be happening now. The second two models, one is where we just have a lot of foothill kind of peaks and valleys, meaning that it never gets that high, but it never goes away. And we have one city, one area, 1 week, 1 month, 1 2-month period, then it's somewhere else. That's a possibility. Or the other one is it just stays in slow burn. We just continue to see several thousand deaths a day, and it just keeps happening and happening. And so what we said is that it could be any one of these combination of models, we don't know. But we have to prepare for the worst one, which is if we do have a big peak this fall, what will it look like, and why is that so important? Because we will clearly overrun all the healthcare capacity we have in this country. We'll run out of drugs, we'll run out of ventilators, we'll run out of the protective equipment we need for healthcare workers. And so that's what we're talking about, is how do we get from here to 60 or 70%? The vaccine comes in sooner than later, that'll help us. But we can't count on that now for what we have to do.
And I had solicited some questions from our community, and you, more specifically, a question was your thoughts on the timeline and reality of herd immunity in the US, which you're talking about, and can the Swedish model be useful in making projections? Is that one model that you looked at?
Yeah, well, first of all, we don't know what the 60 to 70% time period will be. It'll depend. For example, we have a large bolus of cases in the fall. That could get us there a lot quicker than if we have the slow burn. Ideally, what we want to do is have as few cases as possible, particularly among those at high risk of having serious disease or death. The older population, people with underlying health conditions that we know put you at higher risk. And ideally, if we could get to that time period when a vaccine might be available. But the problem with that is you really have to get into shutdown mode to slow that down. I mean, look here in this country right now, even though we have been in shutdown mode of some kind for the past 6 to 8 weeks at minimum, we're still seeing some of our highest numbers ever recorded. And while the outbreaks in New York and Chicago and New Orleans are subsiding and we're seeing those numbers come down, there are so many new cases and deaths around the country that we're actually seeing an increase in cases and an increase in deaths as opposed to disappearing. So I think that we don't know where that number is going to go. Let me comment on the Sweden experience, because this is one that's often misunderstood. And I think we have to be very cautious about what you can interpret from this. Through February and early March, Sweden basically was an outlier among its neighbors of Denmark, Finland, and Norway, where they didn't put into place the same more restrictive population movement issues. They did close schools for a while. They did suggest people be limited in their contact, but it was pretty somewhat, you might say, laissez-faire, but it wasn't without recommendations. And then all of a sudden in March, the countries diverged. The Swedish numbers went up quickly from literally in the hundreds to over 10,000 cases, with a sizable increase in deaths. And then the cases in the other countries continued to increase, but at a much slower rate. The Swedes have suggested that, well, they're getting closer to herd immunity, but when you look at the studies they have, they're talking potentially as many as 20% have been infected and are immune. Surely does not get you even close to herd immunity, which has often been suggested. They also have had major numbers of deaths in the long-term care facilities. Puts their death rates among some of the highest in the world. You know, if that's the model we want to follow, so be it. I don't think so. I think that they haven't at all had the ideal. So I always worry when I hear people talking about models of diseases for certain countries. It's one of the things we have to understand is the virus itself is determining a lot of what happened. For example, in Italy, there was a case in point where everyone talks about how bad the problem was in Italy, but it wasn't that bad in Italy. It was really bad in Milan, in the Lombardy region of northern Italy. Rome and the southern part of Italy had very little activity, relatively speaking. So we've seen it in this country. You know, no other city or metropolitan area was like New York City. Why was that? And so I think that over time, we're going to see that this virus is going to be the great equalizer. And what I mean by that is eventually, whether you're a blue state or a red state, a blue county or a red county, you're going to ultimately be a COVID color county. And we're going to see widespread transmission throughout the entire United States. It's just in the less population density areas, it's going to take longer to get there, but once it gets there, it'll spread.
And speaking of the red and blue states, and I saw a poll this morning, even a difference by political party on if you think that the death rates have been underreported or overreported. Certainly a difference in how we respond and should we shelter in and how long. And it's very complicated, but how do you even begin to lead through the type of division that we are seeing?
This is going to be a hard one in that we are a very divided country now. But at the same time, I think, unfortunately, it is us against the virus, not us against us and the virus. And as this disease spreads into more and more populations, and we see going from 5 to 15% to 60 to 70%, virtually all of us are going to know people who will die from this. We're going to know many loved ones who will be severely ill and some will die. We're going to have a very different sense of this in 12, 14, 18 months from now. And I think that the challenge we have right now is that so many people see this as an immediate issue. You know, they have had economic suffering. There's no question about that. I have a good friend that's likely going to lose his business. I know people who are on the ropes because of the financial straits that this has created. And I don't want for a moment to minimize those. But at the same time, this is a disease that is now the #1 cause of death in this country. And it's going to only increase in the number of people that it impacts, and people who are not just in long-term care, not just in prisons, not just in meatpacking plants, but are going to be every one of us out there in the street. And when that happens, I think you will start to see people take on a very different approach to what it means to try to protect ourselves against this. We just, at this point, I don't think have done a very good job of helping the public understand that this is going to be in the works for many months to come. And it's not just going to be over with in the summertime, as some have led you to believe.
Well, I know you have been a voice of that, to say whether, you know, a baseball analogy, we're at what, end of the first, beginning of the second, or you're a Midwest Iowa boy. This isn't just a blizzard, right? This is a long winter.
Yeah.
That can go. So if you have any other analogies that are helpful, but I know those are a couple that can kind of put it in perspective for people.
I have. I think that's what's really important. And also, I think the other analogy, if I could use, is that we're all trying to figure out how to thread the rope through the needle. and how we're going to not shut down our country and literally kill society as we know it. At the same time, this virus is killing people. And we have to be very mindful of the fact that we just can't let this go willy-nilly, or we will bring down our healthcare systems, and many, many more people will die, just not from COVID, but will also die from all the other conditions they can't get medical care for. And somehow we have to find that middle ground where we are able to open up society sufficiently that we can move on, we can bring back some employment, and we can also protect those who are at highest risk of having a serious disease outcome. Frankly, today, if you're a young adult, your chances of having serious disease or dying from this virus are very, very low. Not zero, it will still happen, but they're very low. That's very different than if you get into some populations, people who have underlying heart disease, people who have had previous lung or blood cancers, people who have chronic renal disease, people who are older and who smoke, people who are overweight. Obesity is a major risk factor today for having a bad outcome with this. So we have to look at those things, and if we can help protect those people to the point of where one day they might first get the vaccine before they get the virus, that would be the ideal outcome.
Viewers, we're going to talk more about this holistic approach to moving forward when we come back.
As the nation's doctor, I often get asked, what should I do if I think I might have coronavirus?
People who are sick should stay home. You don't go to an emergency room, you don't go to a clinic. You get on the phone and you ask for advice and instructions from your physician.
We don't want you to go into the ER or the doctor's office without talking to them first, because you might spread coronavirus to someone else. Please visit coronavirus.gov for more information.
Today, more than ever, you need fast, reliable internet. At MediaCom, we want you to know you can count on us. Our fiber-powered 100% gigabit technology network was built for the future. We have enormous capacity and power, and 99.99% network reliability. So even though these are uncertain times, we're prepared, and you can be certain we'll keep your world connected.
Welcome back to Resiliency Matters. We're talking with Dr. Mike Osterholm from CIDRAP and the author of The Deadliest Enemy. Mike, we spent the beginning of our time talking about preparation, the survival, and what we need to be doing, especially as restrictions are eased up. Let's move into that adaptation and growth and thriving. Another question we got from a community member said that she's heard you speak, and you said we'll need to learn to live with COVID-19. Her question, how would you describe what human resiliency and thriving look like alongside COVID-19?
First of all, we have to accept the fact that there are going to be many, many deaths associated with this pandemic. There's just no escaping that. There'll be many serious illnesses. And what we have to figure out, as I've said, by living with this, is how do we get through that? How do we isolate people to protect them as much as we can without letting them be isolated? That's a big challenge for us. How do we actually share our best of our humanity at a time when we're telling people not to be close to each other? And then when we do see more people infected and they recover, and now we believe they will be able to be in the community, not at risk of either getting infected again or transmitting the virus to someone, how do we help them outreach to others that need their help, who have not yet been infected, but have been literally sheltering in place in a way that, from a mental health standpoint, is a real challenge in just everyday life. So from my perspective is, number one, the first lesson of resiliency with the pandemic is to know that you have to go into that mode before you're ever done. You think of every day as a battle, and every day you have to go into resilience mode. How do we help each other? How do we take care of each other? How do we support each other in terms of, if I can't get out because I'm being sheltering in place, that I know I'm going to have someone going to the grocery store for me, or I'm going to have someone pick up my mail. And I think those are the kinds of things that may not seem like a big thing, but over the course of months, they become huge. So first of all, let's take care of each other. Number two is, we have to look at what is it in society that we need to really run. You know, you can say, well, we don't need to have restaurants, we don't need to have certain other institutions or businesses. But on the other hand, that's someone's livelihood, that's someone's everyday work. And if we can't do that because we're trying to reduce the transmission of the virus, and the question we have to ask is, then how are we going to help them? How are we going to take care of those people? And I'm very concerned that as I see the duration of this lasting many, many months, we're talking about a economic program to help people out for just a couple of weeks to months, just a month or two. We're not talking about it for long duration. So now is the time for us to think about how are we going to also do that. And finally, when this is all over, we need to figure out how we bring ourselves back together. I worry that there'll be division among us, people who are losing their jobs, they're losing their companies, their businesses, how they're reacting to what governments are doing to reduce risk. At the same time, I see intensive care units around this country, even now, right on the brink of overflowing with patients, when at that point, that's when care really becomes a significant challenge. And so I think we're going to have to also figure out at the end of this, how do we bring people back together and learn from us versus the virus versus us and a virus.
And we'll link, when we share the show, I mentioned Joe Rogan, you had a great interview. I found it really helpful with Peter Attia, your New York Times editorial that is addressing some of what you're discussing here. Are there other resources that you want to make sure we steer people toward beyond the stay in tune with what CIDRAP is doing, of course?
Yeah, I think CIDRAP is probably the primary resource for people from around the world. We are now seeing routine visits from over 200 countries and territories. It has become a one-stop shopping location because we bring the best of all the content from around the world to the site. We also have a very active news team that keeps people current on what's going on. So I would recommend that as a free site, a location where one can get that information. It's www.cidrap.umn.edu. I think the other piece of information that is important is that be cautious about information you get. Today, we see so much misinformation on the internet. We see it in our news shows. There are so many talking heads. You know, I have just gone through a kind of personal battle with that, where I wrote an op-ed piece in the New York Times about 7 weeks ago, indicating that testing would be a real challenge, not because we didn't want to do it, we did, but the reagents, the chemicals that we need to run the test were in very short supply because the whole world wanted them. And yet we had people out there telling everyone to get tested every day. And there was no reality to what they were recommending versus what the reality was of what was available. And so we've run into these kinds of things. And I think that you want to find trusted and believable sources of information who help navigate this whole situation for you. And be careful of anything that makes grand, over the top of the moon recommendations or conclusions. As H.L. Mencken once said, you know, in most cases like that, they have answers, but they're wrong. And so I think that you want to find the trusted sources. The CDC is a very good one. Places like CIDRAP can be also very helpful.
Excellent. Let's talk about hope. You also say, you know, we can get overwhelmed, even with a realistic, optimistic perspective, that you try to hold on to that hope. If you break down hope, I think it's really about believing that there is a path. You know, we can go from A to B. There is we will get through this. There is that future. That there's an action available that we as individuals, communities, countries can take a first step. We see what that is, and then there's support, that we have people that are with us to help us take that first step.
Well, thank you, Molly. This is actually the part of the interview where I turned the camera back on you, because in a sense, you're the resilience expert, and we're all looking to you to help us as we go through this, how to get through it in the most positive way, and how to bring the world's population with us. As you mentioned, hope is a very important thing. Now, from a science standpoint, hope is not a strategy. But from an emotional and I think community-based standpoint, it's everything. It's about what people must remember. One, we will get through this. It will end. Number two is how we get through it will determine so very, very much who we are at the end of it, how we take care of people. And number three, I think that if there was ever a time when we need to understand how much we need each other, not just our family and friends, but neighbors, people we don't know in our communities, people from around the world. This is really a time when that's important. You know, I do a podcast on a weekly basis that's on our website, and I always try to end it at the end of the podcast with a comment about just being kind to someone. I think this should really illustrate for us how vulnerable we are as humans, and how resiliency is as much about human spirit as it is anything about a fact. It's as much about the willingness to extend oneself to help someone else, knowing full well that reciprocity will occur, and that the days and the hours that you need that help, it'll be there too. So I just want to reemphasize how important I think hope is. And I hope that we have the opportunity to work with people like you as we go forward, because your message, your ideas, your ability to help this conversation and make it a real thing is very, very important too.
Well, thank you. And I think this whole process is top down and bottom up, and there's a time for everything, right? From top down, we need the science-driven strategies and policy, and we need leadership so that we can quickly manage risk and respond to bad stuff that's coming down the pike. We need all of that. And then at the end of the day, I think resilience will always be bottom up, because it's in community, it's person to person, it's that sharing of resources and kindness and relationship. And so it's gonna take both. And so thank you for that. You've always had an appreciation of how our work dovetails, and I do as well. So I'm thrilled that you've been here with us today. Any last words? I know you're going to head off to another important conversation to help a lot of people, to keep hope alive for a lot of people. Any last words you'd like to share with us?
I think that the message that we all want to share, need to share, and will benefit most from sharing is, number one, remember, we'll get through this. It's not going to be over next week. It's not going to be over next month, but we will get through it. And number two, just be kind to everyone. You know, I'm speaking as a scientist who deals with numbers and cases and people dying. And yet at the heart of what I should be doing or thinking is all about just being kind. And so I think if there's any lesson I've learned from people like you about resilience, it starts with hope and kindness, and it goes from there. And we're surely going to need that in this particular situation. So I thank you for all you're doing, and what it is that with time, we all want to see that day in the sun with no COVID virus anywhere around. And we've gotten through it.
And perhaps we get to those stages of growth and possibly thriving. That's my hope. So thank you again, Mike.
Thank you.
Thank you, viewers, for joining us on MediaCom MC22. And do remember to take care, and that we thrive together.